Oh, I missed it. All right. So welcome, everyone. This is going to be a podcast about return to running, practical evidence-based wisdom. We have two great guests joining the Running SIG today. We got Eric Hegedus and Tom Goom. Eric is a professor and department chair at Tufts. He's been practicing PT for 35 years, mostly working with athletes that are primarily runners and pickleball athletes. He's authored over 100 different manuscripts, is an international speaker, very knowledgeable on this topic, has some great papers out there. Thank you, Eric, for being on. And then Tom, he's from the UK. He's from across the pond, international speaker and keen runner. He specializes in running injury and has published on tendinopathies, running gait, and athlete empowerment. He's well known because of his website and his social media content through runningphysio.com. So Tom, thank you also for joining us today. So our goal here is to identify and apply key criteria for safe return to running across injury types. We want to use individualized load management strategies to guide runners from cross-training to full return to running. And we want to talk about integrating objective and subjective screening tools in the return to running decision-making. And as we know, and why you might log on, is return to running is a hard thing to get right. It seems like there's a lot of variables that go into it and so forth. Tom, do you want to talk about why return to running is so complex?
I think it's exactly as you say, Matt. There are just so many variables to think about, and it's so different between different individuals. And I think naturally we want some kind of recipe, particularly a training plan. We say, well, we just follow this return to running plan, and they'll get back and it be successful. But actually, it's a lot more complex than that. And I think there's a lot of judgment we need as health professionals to try and work out when we think someone may be ready. And that will take into account pathology and injury, stage of healing, their symptoms, if they're severe, if they're irritable, or if they've calmed down, their response to load, and obviously their goals. Where do they actually want to get back to? So I think it's complex because there's a lot to think about, a lot of judgment needed.
Yeah, that's true. Eric, anything to add about that complexity of return to running decision-making?
Well, I mean, I'll maybe paraphrase Tom here, which is returning to running is complex because people are complex. And so the return is only roughly linear under the best of circumstances, and very often isn't linear at all, which requires lots of clinical thought, lots of back and forth with each individual runner. There's psychological, biomechanical, and physiological variables, all of which you're trying to have control of and manipulate to the most effective fashion for an individual patient. So that's what makes it complex.
It makes it fun as well, I'd say. I mean, I'm glad we do not have a cookie cutter type of profession, right? Otherwise, I'd get bored pretty quick.
Absolutely. I mean, just to highlight the individual variety you can have, I've had some patients come to me who haven't run for 2 years and have been told that perhaps they've tried everything and they can't come back. And they've said, my goal is to reach half an hour, and I don't mind how long that takes. If it takes me 6 months, if it takes me a year, I'm prepared to give it as long as it takes. So that's one presentation. Also, in literally the same week, had a patient whose goal was to run to do 5 Ironmen in one, which had 141 miles of running, and we had 6 weeks to get him there. So, like, this is the reality of it. They can be so different, and then for both those patients, we have to work with them and collaborate and try and find a way that works for them.
Yeah, that's difficult to decide as well. And there are some kind of tools out there to help with this to a point, and none of them are going to be fully inclusive of everything we have to consider. But there is a running readiness screen out there. And I believe if I tracked it back right, it's Catherine Harrison et al. Kind of came up with this idea of having these 6 criteria that help identify whether someone's appropriate to start returning to running. And Lace Lukey validated with Division III athletes here just recently. And let me go over what was included in this running readiness screen. And this is completely physical, right? Okay. And then I know you guys have some, if you were to have your own readiness screen, I'm interested how that would look as well. So first off, let's just go over what is on this one here. So 6 different criteria, and they're binary. So yes, no, did the subject or the athlete pass? Okay. The first one, hopping. It's 1 minute of hopping, double leg hopping, and they're to maintain a pace of 160 hops per minute. So all these are 1 minute tasks, and it's qualitative, where you're looking at, does the form look all right? Are the knees collapsing in or anything like that? Or are there symptoms? The second item on here would be a plank, as a 1 minute prone plank. So looking if the weight is equally distributed and if there's any reproduction of symptoms there. There's a 1 minute step up test via a metronome pace of 160 steps per minute. The first 30 seconds you're leading with the right leg or left leg, and the last 30 seconds is the other. Okay, looking for a good concentric eccentric control with that. The next item here is a single leg squat. So with this, there's a metronome of 80 beats per minute, and they are to maintain that rate with the squat, up on one beat, down on the next. So it'd be as that. So looking for a valgus collapse often there and control. And the last variable is 1 minute of a wall sit. So there's a physio ball behind them. They're down at thighs parallel with the ground, looking for ability to complete that. So with this readiness scale in D3 athletes, those that were successful with 3 or less, only successful with 3 or less, they were almost nearly 5 times more likely to sustain an injury that season. And this is within track athletes Division 3-1. So it has some power within this study, this validation study with Division 3 track and field athletes. But in my mind, it's probably not perfect, and there'd be other things we're concerned about, right? Or we could think about what might that look like for either one of you guys? And I know, actually, Tom, let's start with you. I know you've been working on this a little bit and you put some thought into this.
Yeah, I like what they've done there, and I think it's perhaps a question of trying to sort of flesh things out a little bit around that, and also thinking about the fact that we're normally testing it in people that are coming back from injury. So I've come up with sort of 4 broad sort of steps to go through, which each will have its own thing within it, and I'll just cover a little bit of that if that's all right. So step 1 for me is thinking about what are the injury or pathology specific concerns for this individual, because your readiness to run tests is going to look quite different for someone who is actually coming back from, say, ACL surgery, and they need to be at certain timescales, meeting certain markers. It'll be different again for someone with a low risk injury like mild tendinopathy, where they're often actually still managing some running, and it will be different once more for a high risk bone stress injury. So for me, I think the first step is really considering what might we modify around that pathology or injury. So that might include thinking, are there any specific contraindications to running? Are they an appropriate stage of healing and recovery? Typically we talk about maybe at least 12 weeks post ACL reconstruction, for example. What would be an acceptable pain response for this individual? Now, we talk quite a bit about tendons and pain response, maybe 0 to 3 during activity being acceptable if it settles quickly afterwards, but bone stress injury is often recommended to be pain-free. So that might be an example where we're going to adapt to the pathology. And what may be signs of overload that we need to pull back on? If you've got someone coming back after ACL reconstruction, is the knee swelling in response to load? Are they losing range? Are they losing knee extension range? Are they reporting instability? So we're coming into it knowing like these are the signs that this is too much that we can monitor for. So that would be my step 1. I think it's got to start with thinking about individual and their presentation. Then step 2 is looking at the subjective readiness. And a lot of this is around trying to determine if their symptoms are non-irritable and non-severe, because that suggests they're going to cope a bit better with the demands of running. So I would be asking questions like, are they managing day-to-day tasks without pain? Can they walk for 30 minutes pain-free? When they get symptoms, are they mild? Do they settle quickly? And if people aren't able to say yes to those things, if they're still getting some pain just walking, it maybe tells me they need a little bit more time to reduce those symptoms. And then step 3 would be our more objective tests. And again, I think these are going to vary a bit depending on the pathology. But in particular, I want to know about things like energy availability. And there's various tests that can be done for that. We like the PEAK, Personal Energy Availability Questionnaire. I think that's good to have as a standard part of our screening, and looking at whether they can tolerate impact. So can they jog on the spot for a minute without pain? Can they hop repeatedly without pain? But you may add in other tests specific to the pathology. So like we said with our ACLs, we want to know that they've got full knee extension, for example. They've got good strength. They've got a quiet knee, so it's not swollen. And then step 4 is the psychological readiness, which often gets kind of overlooked. And there's a couple of things here. One, I want to know what their perception of return to sport is. Do they think it's going to be damaging? And 2, do they have any signs that they're likely to overtrain? So this might be exploring our attitudes and beliefs around training, the external pressures. Are we going to give them the green light to return, and they're going to rush back into the training errors that brought them to us in the first place? So that's just some of the thoughts, but I'd be really interested to see what you might add or change within that.
Eric, what do you think?
Well, so I promised that Tom and I did not collaborate before this, and his answer is more detailed than mine was. I don't know if you all know this. I did my PhD work around these physical performance tests and the value of them ultimately. So I just stuck to kind of like, okay, simple answer, what would I do? So I would do a single leg squat because it allows me to examine motor control. I like that as a test. I would do a medial hop. And the reason medial hop is it takes not only stability when you land, but it shows the dynamic strength of the gluteus medius, which I think when I look at runners, a lot of times their gluteus maximus is super strong to testing, but their gluteus medius is quite weak in comparison. So that's why I have that one there. The ability to accept weight repeatedly. So I do a 40-yard hop for time, so that they have to do a maximum effort. Now, of course, if they have a stress fracture, I'm not doing that one, but we're talking about, okay, I've rehabilitated them. Now I want to see, can they accept weight, and what does that look like? And can they accept weight when they are pushed to go as fast as they can? So that's what I want to see. And then I'll do some kind of high intensity interval training. Even if it's on a stationary bike, I'll have them get up and down for 30 seconds and pedal as hard as they can and do that for 10 minutes. I want to see what is their psyche like, and how are they reacting from a cardiovascular fashion when they really push themselves. And then as Tom mentioned, again, I promise we didn't collaborate before this. I like some kind of psychosocial questionnaire. For me, there is one called the Endurance Sport Self-Efficacy Scale. The reason I like self-efficacy is it is a positive factor that counteracts lots of sort of negative factors like anxiety, depression, fear of return to sport, all of that stuff. Self-efficacy is a very important variable in sort of countering all of those things. So that, given a short list, that's my short list.
Yeah, so complex, right? I love the idea of looking at how they accept load physically, right? And repetitively. That's so important in my mind. You got to be able to jump before you run. And if you look through, Eric, you wrote about this 6-phase return to run framework. And a big part of that is the cardiovascular. I think that gets overlooked. You highlighted that more than I think others do. And 2, you did talk about also the psychological assessments that are out there and available. And you mentioned the one that you like there too. And there's others. And Tom, I know you talked about the energy availability questionnaire as well. So all those are all so important things, such important things to consider. But Eric, do you want to talk a bit more about your 6-phase return to run framework?
Yeah, sure. Thanks for asking that. So I have to first acknowledge, we said these are complex people. And so on that paper with me are actually 2 college runners. There is also James Smoliga, who's a PhD in exercise physiology, and there's Kevin Ford, who of course is biomechanist extraordinaire. So we collaborated to write that paper because I would not have done it justice writing it myself. So thanks to them. So we divided it into 6 stages, but you could have a 4-stage or you could have a 8-stage. It's a guide, and I would hate for people to use it as a recipe, but roughly, without boring your audience, here's what happens. In the beginning, you're doing cross training only. That's phase 1. And then phase 2, cross training, 5 to 25% of training load is running. And then phase 3 is 25 to 50. Phase 4 is cross training still, but 50% of your training load is running. Phase 5 is, okay, we're thinking about returning to sports. So somewhere more than 50% of your training is running. And then by the time we get to phase 6, we're thinking return to competition. So definitely more than 50% of your training load, and maybe up to 100% is running, is working on your relationship with the ground, so to speak, and very, very sport applicable. So again, cross training, a big part of that. We've had great success doing this. And the reason that we wrote it is because we would get athletes who were broken, so to speak. They had been solid college runners with great potential, or solid high school runners with great potential. They would come to college and they would, every time they got over X mileage, bone stress injury would happen, or tendinopathy would happen, or whatever it happened to be. And again, back to Tom's point of everybody's a little different. Some of these people, that happened when they did more than 35 miles a week. Some of the people, it happened at 70, and some people could run 95 and have none of those problems. And so, because they were so different, we took the ones who tolerated less load and really did lots of very aggressive cross training and produced conference champions on 30 miles a week, which people would say, oh, you can't do that. Can't do that, but we did. So that's where this comes from.
That's incredible in reality. So, Tom, what other thoughts do you have on this?
I have to say, I absolutely love that paper. It's one of those ones where I read it and I'm nodding along the whole way in agreement. I thought it was fantastic, and there's lots of great stuff that I took from that. So yeah, I think there's so many benefits potentially of bringing cross training in, and I love the way that 6-phase approach gradually progresses the running, because ultimately when we've done our screening, we need to test some running. We have to. That's the only real way we can know if someone can run. So that would almost be one of our objective tests in the screening. I often start with maybe a short test run of as little as 3 to 5 minutes to see what's the symptom response like, and usually capping it at that because we don't know what the delayed response will be afterwards. But yeah, I love the way that phase builds the running, integrates the cross training and everything across those 6 phases. And I think I use quite similar principles in my runners with cross training. So I try and encourage them to mirror their normal training with their cross training, so it looks similar in terms of duration and intensity. I think that's quite a good way of doing it. I sometimes encourage a top-up approach, which is similar to what you're doing. So if they wanted a 60-minute training session, but they can only run half an hour at the moment, can they top it up with half an hour on the bike? And I also try and keep some social cross training in there too, because I think one of the things that us runners really miss when we're injured is the social side of the sport. So can they go and join the club run with their fellow runners, but on their bike? So they're still there, can they do the social elements as well? But yeah, I think my approach I would hope would be similar to what you've discussed there.
Matt, could I ask Tom a follow-up? Would that be okay?
For sure, of course.
So Tom, as you're doing this mix of cross training and running, as a runner yourself, are you thinking this should be at the intensity of a tempo run? This should be at the intensity of a threshold run? Does that enter your mind as you're prescribing intensity of exercise?
Yes, it does. So I think about what would your ideal training look like at the moment? So classically with runners, where in the UK we've got a lot of marathons coming up in April, so now they will be starting to build their long run distance, which usually is going to be low intensity, long duration. So we might expect an RPE of 2 to 4, something like that. So that's what we might want to mirror. Let's do the running at the volume and that you can cope with, that are acceptable for your symptoms, and then maybe we top up at that same 2 to 4 intensity. And similar, if we're trying to replace a tempo session, do we want to aim for maybe that kind of 4 to 6 characteristic? Similar with intervals, and it's trying to think, how can we best replicate it? So let's say someone's usually doing intervals and they're involving 200 meter fast intervals with 100 meter walk. Well, could we do intervals like that on a rower? So it's going to be a similar duration. So yeah, I try as much as I can to do that, but I'm also very keen on working with running coaches and people like exercise physiologists, because they have that performance training. My mind is always thinking more like, how do we come back post injury? How do we consider the injury? But I do think it's good to team up for those performance characteristics too.
Yeah, Eric, isn't that one of the first stages of your 6-phase approach, was identifying the team? Yeah. So on that, I kind of want, we kind of had a plan here, but I want to jump ahead a little bit to the TRIMP concept and workload monitoring. I feel like this this blends into that really well. If we're to with workload monitoring, typically we're doing some type of volume by intensity calculation more than just mileage, right? So if we're doing this with cross training, as Tom mentioned, you try to simulate that 20 minutes at RPE or whatever, if that was what was on the training docket with the team or whatever it is, if you're doing that on the row or what else. Can you, Eric, do you mind kind of getting into what the TRIMP concept is that you use?
Yeah, again, all credit to Jamie Smoliga here. TRIMP stands for Training Impulse. And the way we arrived at it is runners are always asking, so how does this thing that I'm doing on the stair climber, on the bike, on the elliptigo, in the pool translate to what I'm doing if I would be running, right? And so we needed some kind of crossover measure. And so TRIMP is really, you take the RPE times the time you spent doing that exercise. So now we're capturing intensity as well as length of time. And it doesn't matter to me whether you're running, swimming, doing a stair stepper, doing a bike, doing an elliptical, doesn't matter. That translates across all of these methods of rehabilitating and or conditioning the cardiovascular system. So that's where TRIMP came from. And then I don't think we use this term. I'm not even sure it's a term. I'm going to say it anyway. You can calculate a grand TRIMP, and that is the TRIMP of each individual piece of the exercise to look at, well, what was my TRIMP for the week? And how does that compare to the TRIMP that I calculated when the runner told me this is what my normal week looked like before I got injured? So you always are measuring these things against each other, and it's just a nice common term that captures all of that stuff, so I know when I'm getting closer to them tolerating their full training.
Gotcha. Tom, do you do anything like that?
Yeah, almost exactly the same, really. We would tend to try and capture RPE and minutes, because it allows you to look at volume and intensity together. And I think it's a good thing to practice with people getting familiar with it. And sometimes as well, it's good to utilize when things haven't gone very successfully, especially RPE. So we had a runner a little while back with some hamstring muscle pain who was doing really well and had reached 10K at his easy pace, so his sort of 2 to 4 pace. And he said he was going to go out and do a faster 5K, and it flared his symptoms up. And I asked him afterwards what he thought, the RP score was, and he said at least 9.5. So he'd gone out and tried to basically sprint the 5K. So that's on me partly for not saying, look, we've done 2 to 4 RP, let's dial that intensity up to maybe 5 and then see how that goes. But it gives people that idea of a dial that's gradually increasing rather than speed being something you just turn on and off. So yeah, I think it's really, really useful to use that.
So Tom's story brings up a great point, which is in most runners that I work with, unless you are very explicit and almost give them a recipe, they go, well, I guess if I can run, I'm going straight to 10 on the RPE scale. And you're like, no, that's not what we're saying.
Eric, do you mind talking about then, like, competitive athletes, how's this return to run look for someone like that versus Tom, you might have more of your recreational athletes that you've been seeing. I'm kind of interested to see you guys kind of compare and contrast what you see with those type of runners.
Yeah, I'm not, as I listen to Tom talk, there may not be much contrast here, but let me tell you what I think about when I'm working with a competitive runner. Number one, as Tom indicated with his case study, very often I am pulling back on the reins. It's not like they lack motivation to go beyond what I've said. So I'm always pulling back on them. An occupational or recreational hazard for competitive runners is they're always right on the borderline between efficiently thin as far as muscle mass versus fat mass versus, oh, we tipped over a little bit. Now we're having eating disorders and we're having energy deficiency and we're having other things, bone stress injuries that happen there. So I'm really aware of that in the recreational runners, as well as, and this is why it takes a team. I certainly can't treat them by myself, as well as, what we found in every single female runner that we had and 50% of the male runners we had, that at some point during the season, they had iron deficiency for the repetitive. So I watch things like overtraining, decrease in performance. When's the last time we've had the blood test? What's your iron level? Those are sort of things in a competitive athlete that I have to watch more for, that are beyond sort of just like, yes, this is the rehab that we're doing, this is the load that we're taking. Those are some additional things.
And I think I do agree. There's similar. There's going to be quite a lot of overlap, isn't there? I find sometimes with recreational runners that perhaps where they're starting with their return to running process might be less, and how quickly they can progress may need to be slower. Because they don't typically have that training history. They don't necessarily have a strength and conditioning history in there that a competitive runner might have. And where they're aiming for is often quite different. So it's not unusual for me to see competitive runners who just want to get to half an hour 3 times a week in recreational runners. Whereas in our competitive ones, it's not unusual for them to want to be running 10 times a week and to have a key event coming up that places quite a lot of pressure on that return to running process. So that then sometimes means it's a race that dictates the progression in that competitive runner rather than their symptoms. So I think those are probably the main differences, because the performance needs are higher. I totally agree with what you're saying there, Eric. It takes a team, and I think it's really good to team up with everyone that's looking after those competitive athletes and help them get back to that high level.
Fantastic. A couple different topics here I want to cover on this podcast. One being Alter Gs and weight eliminating things, HydroWorks, suspension type of treadmills, and so forth. I'm lucky I have access to some of these things where I work and so forth. What are your thoughts on these type of tools and how they might be used and not used in the return to run decision-making process?
Tom, do you want to go first? Go ahead.
So I would say that they do have their uses, but in my experience, the biggest issue is consistent access. So if someone can access it regularly enough to get the benefits, then great. But in most of the patients I see, they don't necessarily have access to things like AlterGs. So we're looking for what is the cross training strategy you can use regularly. If that happens to be an exercise bike that you've got in your home gym that you can use as and when you want to, then that's often more what I would tend to lean towards.
Yeah, and so that the folks at HydroWorks don't get mad at me, it's not that I'm not a fan of HydroWorks per se. I'm not a fan of water as a rehabilitation modality in runners unless there is absolutely no other option. And there are cases where that happens, where there's absolutely no other option.
Tom, I know there's the you have this concept that you kind of follow, this no running or some running concept. How, do you mind to talk about that, especially if there isn't access to an AlterG to help bridge that gap from where we're starting with some of our athletes, that being no running, to ultimately over the ground running again?
Yeah, so I think one of the distinctions we want to make with runners is actually quite a few of them, particularly with things like tendinopathy, patellofemoral pain, iliotibial band syndrome, actually will come in and identify a level of running they can continue with. So they'll be able to continue some running at an acceptable level. And that's a lot easier to work with in terms of your return to running process, because it's a little bit less about establishing, like, right from the start whether they're ready to run, and it's more about finding the sweet spot with them, an amount that they can continue and progress with. Whereas with those runners that you cannot find a tolerable level, even literally 2 minutes is too provocative for their symptoms, they are going to require different management. And that will be much more where we're going to look at the cross training options. We're going to focus a lot more on the rehab strategies, a lot more on calming things down to actually prepare them for the running process. But it is a balancing act, because the longer you keep someone away from their sport, the longer it takes to get back. So often there is that balance, and that's where hopefully the cross training can help, because you're keeping them fit, you're keeping them active, and hopefully that makes that transition back a fair deal easier.
And Matt, if you wouldn't mind, I'll go back and finish the AlterG HydroWorks discussion, which is, I like the AlterG. In my experience of using it, there's a couple things that you need to be careful of as you use it. So first of all, it changes the runner's running pattern. Generally, even if they're a rear foot striker, they become a non-rear foot striker when they're on the AlterG. They can also go much faster on it. So for example, if you're doing a bone stress injury of the metatarsal head, that's probably not a good thing to put them on. And after you get to sort of 70% of body weight, I didn't see much difference between 70% and 100%. So it wasn't so sensitive that 75 was any different than 70 or 80 was any different than 70. So I have used them. The competitive runners do have more access to that. But I'm just not a fan of water rehabilitation. I don't think it stimulates the system enough, especially with bone stress injuries.
That makes sense. Good. How about shifting to footwear? All right. So this could, most of my runners are see this as why they got hurt, a lot of the time and stuff like that. They want something to blame. It's footwear or whatever it is. And this is a loaded topic. We could talk about this forever, but let's quickly, what are your thoughts on this? Tom, do you mind starting us off here?
Yeah, it's definitely something that runners are keen on, and I'm sure you both will experience them turn up with a bag of all their different shoes. A few things I have with this is that one of the things that people struggle with is change. And we know that change of training is an issue, change of recovery is an issue, but change of footwear is potentially an issue too. So I would be very, very cautious recommending new shoes to a runner, because we're introducing change, and it's also quite difficult to predict their response. The studies I'm aware of tend to show quite varied individual response to different types of shoes. So I'm more inclined to work with the shoes the runner's got, and then to see if there's any relationship between those shoes and their symptoms. Are they saying their symptoms are much worse in a certain shoe or much better in another shoe? And can you reason through why that is? So we had a runner recently, for example, with some great toe pain, and the shoes he was wearing, older shoes, are completely worn out. They had no rigidity, and there was a lot of flexibility through the forefoot. And when he ran in those, they were pretty uncomfortable. But when he ran in newer shoes with a firmer forefoot, virtually no pain. So you can reason through, okay, well, that more firm forefoot section requires less movement of the great toe. It's more comfortable for him to run in. Okay, that's a situation where we might say, right, it's time to ditch those older shoes. Let's focus on these ones you're comfortable in. But I think a lot of the time we need to be a little bit careful about recommending specific shoes. We need to go on that kind of individual response and reasoning.
Anything to add there, Eric?
Yes, the shoe that you run in that doesn't give you pain or injury is the right shoe for you.
Well, that is correct.
Yeah, and I completely agree with that. I think that should be written up on our clinic walls somewhere, because that celebrates the individuality. We have a local runner where I am that's affectionately known as Flip Flop Mark, because he does all his running in these kind of flip flop style running shoes, and that works for him. And he doesn't have any issues doing that. So there's no need to change that for that particular person. It works for them, and I think we can celebrate that.
I love that. A good buddy of mine, Alex, is the Croc Alex. So he's in Crocs. So how about during the return to run process, what are your thoughts about changing gait and form and so forth? Either you want to tackle that topic?
I have a short answer, so I'll go first. I'm sure Tom has a better one than what I'm going to give you. And that is that as part of the rehabilitation process, if the athlete shows me a difficulty accepting the full load at their full stride length, I don't mind suggesting that they shorten their stride as we reintroduce running. But I am very careful because of what Tom said earlier. And runners, like everyone else, have a difficult time dealing with change. So if I get the gist that that's going to be something that's going to mess with their psyche, then I don't suggest it at all.
Yes, very similar for me. I think we do need to be mindful how we communicate gait changes, because running's such a huge part of most of the people's who we treat, most people's lives. So if we come in with language that really undermines their confidence and pulls their running apart, I don't think that's positive. So I use the term fine tuning a lot. So, I'll pick out the positives of the running style. I might say, you've got a nice upright running style. Your propulsion looks really good. If we can fine tune it by increasing your step rate a little bit, I think it might feel more comfortable. So it just gives them that idea that, broadly speaking, they're in good shape, they're doing well, but we might want to tweak it. And that's kind of true of what we're doing as well, is most of the changes we want to make, we want them to be subtle, because if they're too big, they're going to shift the load to something else that won't tolerate it. So I'm very much of a mind of, is there something clear in their running gait that they're doing that may be placing more stress on the sensitive tissue? Might there be a subtle strategy that we can try that would help? And then we test it and we see how do they feel using the cues that we use. But as much as possible, we keep it really simple.
I'm guessing I know where you guys are going to go with this next question, but what are your recommendations with running surfaces then during the return to run process? Either you want to talk about your experiences and expertise on the topic.
I think a lot of it has to be about the goal surface, doesn't it? for me. And we have runners sometimes that say, well, I could do a return to running on the treadmill. And my response will be, well, is that what you want to run on? Is your long-term goal to train on the treadmill? If it is, great. But if it's not, the problem is we do a graded return to treadmill, and then at some point we almost have to do a graded return to road running too. So as part of that kind of readiness to run test, that test run is ideally going to be on their target surface, because if they can manage it on the target surface, we can build from there. I like to have as few changeable things as possible. Even with that test run, if I can get them to do it without any walk breaks, great. Just 3 minutes of running, because then that's something else I don't have to change. I don't have to remove a walk break as well as build the distance. So yeah, that tends to be my goal with it. But yeah, interested to see what you both think.
Yeah, I agree 100%. I think about the surface, but also the terrain. So do they typically run, if they're a recreational runner and they run mostly on the road, which means the road is usually tilted for drainage, then I'm aware of that, and that's part of their return to run. If they like to run trails, then that's what we target to return to. But I also sort of want to know, did they run gently sloping terrain? Do they run mountainous terrain? I used to marvel at the devastating effects of taking. So when I practiced in the state of North Carolina has everything from flat sandhills to mountains in Boone and areas like that. And so I used to always marvel that mostly these athletes would train 99% of the year on slowly graded surfaces, gently sloping hills, and then once a week they would go away for like a camp to get together, to build camaraderie, to all that stuff. But they would go to the mountains, and everybody would come back with foot, knee, and low back pain, because now to get up the mountain, you're running on your toes for like 15 straight minutes, and get down the other side, you're pounding your heels and hyperextending your low back, and all of a sudden everybody came back with different sorts of injuries. So I try to keep in mind not only the surface, but also what is the terrain that they normally train on.
I think there's also some interesting perceptions from runners about surfaces that perhaps come from previous attitudes. Like they'll assume, well, a harder surface will cause me more problems, but actually, quite often when we talk about it, that's not the case. That actually a firmer surface allows your leg to behave a bit more like a spring. And, I would often think it's harder as a runner to run on something soft, certainly sand or soft grass, because you've got nothing to spring off. So I think sometimes we want to have that discussion with the runner and let them see, yeah, actually, no, you can run on road if that's your goal. But what we want to find is that manageable amount for you, and then progress you towards where you want to be.
I agree that running surface misunderstanding myth is up there with the running shoe one for a lot of people, I feel like, to a point. So I want to try to make our athletes or runners know that it is safe to run, right? I don't want them to have these unnecessary false beliefs that might keep them from running, like, this is going to be bad for me because it's a hard surface or whatever. How about a hard thing sometimes is, where do we fit in the strength and rehab within the return to run process? Do you try to do it if they're doing like harder days or easier days? Is there a rhyme or reason, or obviously there's a lot of variables to consider, but generally, what are your thoughts about where this fits into that schedule?
Yeah. So, the competitive runners don't mind lifting weights, but it's sort of like eating vegetables. They know they have to. It's not their favorite thing. They don't love it. Honestly, for me, on the lower trimp days is when I say this is probably the good day for you to do strengthening. My method is no more complex than that. I know Tom has a better answer than that.
I don't know if I do have a better answer, but I think that really does show that the value of things like trimp, because it's really, that's a really nice way of sort of showing the runners how to utilize it. I have a few different approaches. Probably the main one I tend to use when runners are coming back from injury is a 3-2-1 approach to the training week. So typically I'll try and suggest the runner has 3 running days, with the running being at a manageable level. So we've got regular stimulus for the tissue, for the fitness, for the confidence, everything else like that. I'll usually have at least 2 days per week, which are going to be rehab based or strength and conditioning. And then one that is specific to recovery. So there's a dedicated day in there that gives you recovery. And that's 6 out of your 7 days of the week, which usually allows one spare, which can be additional cross training. It can be another strength and conditioning session. It could be another run. So that tends to be the rough framework that I do, keeping the running and the strength and conditioning days separate. But most of the runners I see are going to be running 3, maybe 4 times a week. So you can do that. And some actually are very new to strength work. So they get a big DOMS response. So occasionally we'll need to go even less potentially. So I might say have a run day, a strength day, and then a recovery day, and use a 3-day cycle through that process. So I think it always, you've got to come down to that reasoning and talking to the patient about what works for them. And I'm a big fan, if you've got time before an event for any level runner, if they've got an event coming up, use that time and plan. How do you get the most out of it? If you've got 6 months, could we have a good 6 to 8 weeks strength training block at the start when you don't have to run so much? And then can we build up the training later and build the strength work down, reduce the strength work as that training for running is increasing, so that we're periodizing it through the process.
Gotcha. That's a great conversation, guys. Right now, we have a couple really good topics I still want to hit, and some questions here. I think a lot of our questions from our viewers are going to be answered with these last couple questions. So I'd like to proceed with those. So Tom, you alluded to this earlier, like the type of injury kind of impacts your clinical decision making, whether it's the irritability, the location of it, or whatever it is. Do you want to discuss that a little bit more at this point?
Yeah, I think it's the type of injury, and also the whole story from the runner in terms of what's their experience of return to running been so far. So if you're working, let's say you're working with someone who's had recurrent bone stress injuries, and their experience has been that they've tried the return to running process several times, and every time they've tried it, they've either flared up their current symptoms or they've created new symptoms. So we know, particularly with bone stress injuries, that we need to be cautious. We need to generally go with a pain-free approach, both during and after training. And we need to be aware of the bigger picture stuff with bone health. So, we've touched on energy availability being part of that bigger picture, strength and conditioning being part of it, psychological drivers and things being part of it. So I think with those higher risk injuries, those ones that have struggled with the return to running process, I'm much more focused on slow, cautious, gradual, consistent approach. And I try and make sure that the runner is kind of on board with that from the early session. I'm not offering any quick fixes, because we don't have them. But if I can keep them consistently building, then we can get them back to where they want to be. And we'll try as much as we can to look at that big picture stuff as well. Versus, someone who's coming in with some mild mid-portion Achilles pain, maybe they're tolerating 5 miles without any reaction. And we can see, because they can cope with that, because they haven't been away from the sport, they don't have that same level of deconditioning, we can probably progress that runner more quickly. We still want to be aware of the bigger picture, but it's a lot of that kind of risk versus reward process. And someone with a complex bone stress injury, the risk of aggravation is going to be much higher. So we're constantly trying to balance that risk versus reward out. And those with lower risks, we may be able to get a little bit more rewards in terms of training progression, but constantly monitoring their response.
I know, Eric, you had in sports medicine some good papers about bone adaptation and so forth. Do you mind, just while we're kind of somewhat on that topic. Do you want to add a little bit about just what bone adaptation, what's happening osteogenically during the return to run process and with other stimulus as well?
Yeah, sure. So agree 100% with everything Tom said, wouldn't modify that at all. I think we have to remember that bone loading is very important in bone stress injuries. And this is why I said before, I'm not a huge fan of water. I think when you completely offload the bone, there's not enough stimulus there to strengthen the bone, which is what we're trying to do in a bone stress injury, right? So our best weapons against bone stress injuries as physical therapists or physiotherapists is mechanical stimulation and mechanotransduction. And if you're not using strength training to do that and to stimulate the osteocytes to remodify that bone, nothing else works. And straight aerobic exercise will not do that. So you have to lift weights. You have to strength train. And it is best if you stimulate that bone from multiple directions. A unilateral stimulation of the bone is what very often leads to bone stress injuries in the first place, is that we're only going one direction, which is straight ahead. We're not cutting, we're not changing direction, we're not, right? And so back in the day when I came through physical therapy school, which is like, I think was back when dinosaurs still roamed the earth, when I was in physical therapy school, they kind of taught me that the osteocyte is kind of this dead cell. It's already grown up, it doesn't do anything, it sits there in the bone. No big deal about it. Now we know that that's absolutely not the case. The osteocyte is the main regulator. It is highly active. It's the main regulator of bone health. It's connected to the vascular system. It's connected to other cells. It's connected and facilitates mechanotransduction, which is how we modify bone. And so if you are going to totally offload the standard of treating a bone stress injury, when I got to one of the universities I was at, was immediately do nothing for 6 weeks. Here's a boot. That is a recipe for disaster. And then we wonder why they have slow healing bone stress injuries, and that when they return to running, the exact same stress injury repeats itself because you've not done anything different. You've not strengthened the bone. That's my soapbox.
Good insight there. One last thing I want to talk about before addressing one of the Q&A that we got from our audience, which was our audience is the Running Sig membership. Some of the viewers are going to have questions about ACL reconstructions and how return to run looks with this. Tom, do you mind sharing your thoughts about returning patients who have had an ACL reconstruction back to running?
Yes, definitely. So I will start by saying I don't see hundreds and hundreds of these, but I do see them come through clinic. Most of the runners I see are more overuse based injuries, but I think probably one of the things that's quite good to share is there's a paper from Ramboud et al. In 2018, a scoping review that looked at some of the return to running criteria after ACL reconstruction. So they did highlight a lack of really high quality studies in this, but they talk about some non-negotiables. So first of all, we need to think about the appropriate time frame, and I believe typically in these studies it's around about 12 weeks post-op. And the non-negotiables were pain of less than 2 on your kind of numerical scale, 95% knee flexion range, and full knee extension range, so reaching 0 degrees of knee extension. And I think these are good measures to have at the very least. You want a knee that is able to go fully straight, and no effusion or trace levels of effusion. So these things are suggesting a quiet knee. We've not got lots of pain, we've not got lots of swelling, we've got good range of motion. But I really think they're the kind of very basic things that we would have in there, and I'd want to try and achieve quite a lot more alongside that. So we want to have simple things like normal, comfortable walking gait. We want to have good strength in the key shock absorbers, so the quads, the calf, hamstrings, the glutes. I would probably be looking at trying to get at least 80% limb symmetry index with those, ideally higher if you can. We also want to see people managing impact. and not just from a symptom point of view, but in terms of how they do it, because we will see some people post ACL reconstruction will avoid loading into knee flexion, and you see it show up in their running gait. So as part of that rehab progression, we might want to get them used to doing some impact and being prepared to take some load through the knee. So I think it's having those non-negotiables, but also making sure that they're ready from a strength, control and flexibility point of view, and then progressing through your impact from the simple stuff like double leg onto more challenging stuff like bounding, ultimately onto hopping, repeated hopping, etc., and then bringing them into perhaps a test run when you feel they're passing all of those tests, really. So I'm really more inclined to be quite thorough with these, because they're not typically coming to you saying, I've got a race in 6 months. And if there's no race, there's no rush. We don't need to rush this process. Take a little bit more time to get that individual ready and make sure that they're going to respond well to it, and then do a graded return rather than feeling you've got to rush through it.
Nice. Thank you. I'm glad you covered those topics. A question that one of our Running SIG members has, and I think it'll be nice to talk about. We've covered a lot already, but can either you want to talk about like low energy availability, REDS, RED-S, whatever you want, all those different terms, and how does that look with your return to running process for athletes that may have had injuries that are associated with that? BSIs, for example, bone stress injuries, but other injuries have been associated with low energy availability as well. So how does that look for you with an athlete like that?
I'll cover that one to start with, if that's okay, because this is an area where my practice has changed, actually. So there's been some really good studies in runners from Whitney et al. I think 2024 was one, where they looked at low energy availability in marathon runners. And if people listening in aren't familiar with that term, it's essentially that someone's not taking on enough fuel, enough calories through their nutrition to meet the needs of their sport and day-to-day life. And in this study from Whitney et al., they looked at marathon runners, and they found, I think it was around 42% of female marathon runners in the study they looked at had low energy availability. And I think it was roughly 17.5% of male runners. And then they found there were some quite significant consequences of that. So if they had low energy availability, it seemed to impair their race performance. So they actually were slower, which is the opposite to what runners might think. They might think if they're slim, they'll perform better. Those with low energy availability had double the risk of needing race day medical attention. And there were some significant differences in the injury rates, particularly in the female runners. I believe the female runners with low energy availability, somewhere around 52% of them had an overuse injury, whereas the female runners without low energy availability, it was around 7%. Now, I would encourage people to look at the actual paper to be accurate on those figures, but it tells a story here that low energy availability can impair performance and it can increase injury risk. And there's growing evidence around that. So what I've changed is now for every runner that we see, we ask them to fill out something called a PEAK, which is a personal energy availability questionnaire from Dr. Nikki Keys. It's a free online questionnaire that they can fill out. We have a QR code on the initial assessment form that we get them to scan, and we say, can you do this between now and the next session? So we're just screening right from the start. And then if we're identifying any energy availability needs, we're recommending that they see either a sports nutritionist or registered dietitian so they get the right support in there. So I think it's a good thing to make part of our regular screening and be aware of, not just for bone stress injury. I mean, that's probably the headline injury we associate it with, but I think generally for running injuries, it's good to screen.
Eric, you had some pretty dramatic statistics that you were talking about before too, and with some, especially the women collegiate athletes that you have seen before. Do you mind talking on this topic a second before we get to our kind of a take-home messages?
Yeah, I think the only thing I would add to what Tom said, which was fantastic, is that low energy availability is not the same as an eating disorder. So people should understand. I know probably running SIG members do get it, but sometimes this is an athlete who believes they're eating healthy. They're just not eating enough calories. I don't think they understand the level at which they are burning calories, right? And so they're just not eating enough. They're not taking enough in. Even if they're eating healthy, they're not taking enough in. That's all I would add, is sometimes it is an eating disorder. Sometimes it's just they're completely unaware that, man, you're taking in like half the calories you need to do the sport that you're doing.
Well, that was a great point. I know with all the college athletes I work with, we screen all of them, and they almost never identify as having an eating disorder, but there's no doubt that they do have some lower levels of energy availability. They're very skinny. They're furnaces at that age. They're 18 to 23-year-olds. They're just burning up calories, and let alone with the training they're doing as well. So I'm so glad you made that distinction there, that it's more than just energy eating disorder. It is like you need a lot of fuel to heal and to perform and to run. So yeah, anything else there, Tom, that you wanted to add?
I'm just going to add, I totally agree on that point. When we speak to some of the sports nutritionists locally, they'll say that elite athletes, might be looking at 8,000 calories or more per day in terms of what they're actually, what their energy expenditure is. And I think you're right. I think in many cases it's accidental. It's something that happens because people don't realize the demands of their sport. I think one of the sort of overall messages we're trying to get with runners is that can they plan their training and their recovery and fueling? Because some are good at planning training, some perhaps struggle with that, and it kind of just fits in whenever they can. But it's much more rare that someone sits down and plans, when am I going to have a recovery day? How am I going to fit my sleep in? How am I going to fuel for this sport? Because that can actually be a huge part of the process, and actually an enjoyable part of the routine. So if you, for example, you do your long, slow run as part of your marathon training, is there a pre-run fuel that you like that gives you the energy during that run? Is there something you can have during the run that keeps you going when you need it? And what's your post-run fueling strategy to top up your energy levels? And it can all become kind of part of that routine to fuel for your sport, and for it to be a positive, enjoyable part of the sport that actually enhances your performance. We talk about risk versus reward. There's really no risk in taking on enough fuel for your sport, I think.
With running, so certainly that is so true. So let's close it out here. Let's get a key take-home message from each person here before we finish up. I'll start. I think sometimes we get committed to timelines out there and so forth. So return to running is iterative. It's a process. It's decisions are being made throughout the whole time. It's too complex for simple timelines. So just keep that in mind. We got to be fluid with this process for sure. So that's kind of what I heard from you guys. Any additional take-home messages for our audience today again?
Tom, do you want to go first?
Yeah, I would just say always adapt to the individual. I think that's got to be one of the key things. And I think if you keep doing that, then you're going to be getting things right in many cases.
And I would say, as much as possible, work in teams and ask for help. Working with runners is one of my favorite populations in the whole world. Subtle biomechanical and physiological and psychological changes, nutrition changes, subtle ones, produce massive effects on the other end. And you need to be alert. You need to be on your game. You need to be a great detective when you're diagnosing the reason for the injury. All of that stuff makes working with runners just one of my favorite populations to work with. I absolutely love it. And I hope that people that are listening love working with runners too.
That's perfect. Well, thank you, Eric and Tom. Like, again, this was gold. You guys hit it out of the park. This topic is so important, and you guys had so many great clinical pearls. So on behalf of the AASPT, thank you. To our listeners, just a reminder to continue to follow the AASPT calendar. We have tons of great content every week, from webinars, the podcast, the journal club review. So thank you for joining us today, and I look forward to hearing from you guys more in the future. Again, thank you, Eric and Tom.